All right.
Okay. For all those that are out there virtually, I'm sure people will be rolling in over time. And what this talk does is allows me to go through some very important questions and questionnaires. The genesis of this talk is really one to try to help the physicians find a way to document what they're experiencing with the patients and what the patient's complaints are, which can help them in supporting their opinions and their reports. So I usually have to go through some disclaimers. We're going to just go through that real quickly for you. I did not say what you thought I said. You did not hear what you thought you heard. Artificial intelligence is no match for natural stupidity. Hopefully I'm not going to be too stupid here, and I can give you some good ideas. A lot of the comments in here come from the guide's book, Evaluation of Functional Capacity. I don't get royalties for that, but I do have to do my financial conflicts of interest, which are always required. So that happens to be with the AMA Guides books. So that's the AMA Guides Evaluation and Injury Causation book. This is the Workability and Return to Work book. This is the Guide's 6th edition book. And then this is the Guide's Disability Benefit Systems book. So again, I keep my day job. I don't make a lot of money from those, with full disclosure. I also get paid by MD Guidelines to review the database from time to time. Again, I don't think that something's going to be come up today. And sometimes I make more money by actually working than giving talks. So that's a conflict of interest for me. Here's a picture of some of my boys at a certain point in time. I also owe them acknowledgments along with co-editors, the staff of AOS, and everybody else. Okay. Can we avoid the unforeseen? Okay. So every time you go to literature, there's a whole bunch of information about questionnaires, right? And you look at these lists, you go, oh my gosh, there's so many pain questionnaires. Where do you start? What do you do with them? Which one's the right one for me? And most importantly, what do I want to use in my practice to help me, right? And that's an important thing I want you to keep in mind, that this is about helping you, helping make your reports substantial, credible, to protect you in case you get an interrogatory, in case you get a deposition, to have a basis of forming and supporting your opinion, right? There's also questionnaires for the spine, right? And every time you look in the literature, they talk a lot about biopsychosocial. So you're going to hear that a lot, right? About all the studies that show that a lot of pain complaints, a lot of symptom reporting, a lot of reasons that people seek workers' compensation, disability, private injury, all those kind of things have to do with other factors rather than just the mechanism of injury, right? Mick Sullivan has some biopsychosocial scores, which are also very helpful and ones that you could think about and look at. And there's also screens for malingering, right? Which is a very powerful term, fraught with a lot of implications. And so I tend to tell people to be careful in using that when they're doing evaluations of patients. But here's an example, right? PTSD. Everybody knows about PTSD, heard about it, right? And there are questionnaires for that, right? That is something that we're not really covering today, because we're really covering people who have injuries and pain complaints, and then how do you bring that into your reports to really make that helpful and supporting your opinion, right? And there's certainly a lot of studies that looked at all kinds of different mechanisms to add up somebody's distress, somebody's concerns, somebody's difficulties. And when you add it all together, you do studies like this, you see that when they're looking at why do people stay out of work, why do people have claims, why do people report certain symptoms, what you see is that you see this clear pattern where the majority of reasons have nothing to do with the mechanism of injury. It has to do with the number one predictors of when do you think you'll go back to work, asking people what they're feeling, right? There's another study, Optima, right? And it said, look, if you're going to try to figure out who's injured, why are they injured, why are they not getting better, why did they not go back to work, right? You're going to see these types of criteria. And this is their expectations, their belief systems, and how they review all the things that have happened to them and what it means to them. Not necessarily the mechanism of injury, right? So this becomes very important in these biopsychosocial models, right? There are well-known questionnaires that look at this for presenteeism, absenteeism, right? So presenteeism is before people are even absent. Some things that are already operating that's going to make it more likely they're going to have trouble in the work environment. And there's a whole bunch of questionnaires that look at that for different areas, right? And what happens if you give somebody one of these questionnaires? What happens if you identify somebody that may be having troubles? What do you do, right? Well, we certainly know that if you know something's operating, if you intervene, it can make a difference, right? Winwood showed that there's all different domains of resilience, right? And how patients handle their injuries. So you could imagine that if you have somebody that has an injury, doesn't seem to quite fit, doesn't seem to be consistent, doesn't seem to have the normal outcomes, and they're claiming limitations, difficulties, which seem to you to be out of proportion to the mechanism of injury, out of proportion to what your normal clinical experience tells you, then they're saying from this literature, there's ways of thinking about people, their resilience, how they handle things, and what can we do about it. And when you look at questionnaires, NASH has criteria, right? They have to be practical, brief, valid, available, lack confounding. In particular, they have to be written to a certain educational level, usually about 8th grade, right? So you really got to keep it at a low level, right? So how do we get to a legitimate questionnaire? How do we ask for these questionnaires that are going to tell us what we need to know to substantiate our opinions, to make our reports credible, to help us when we're in the middle of a deposition, an interrogatory, when we're trying to justify our opinions on somebody's impairment, ability to work, right? All right, so first, how did I get in trouble? Well, I had somebody came into my office with back pain, longshoreman, right? And so the claims person had called me up and said, look, Mark, this gentleman says he can't go back to work, but we don't know much. He's been treating with some physical therapy. And I saw this guy and I said, okay, I'm going to show them how this gets done. I'm going to do a careful history, careful examination, and I was going to document everything, right? And so this guy said, oh, Dr. Hammond, I like you. I like your office staff, and everything's great. And I sent him into some physical therapy, and I was seeing him back every 2 weeks, and I was documenting he was 30% better, 40% better, 50% better. He said, I'm great, I'm great, I'm great. You're the greatest staff. And then I finally said one day, remember, this was a Thursday, by the way, I'll tell you why I remember that. And I said, look, I think it's time. And he said, time for what? He said, time to go back to work. And he said, what do you mean? And all of a sudden I started to get very nervous. I said, well, you know, why have we been treating you? And he said, well, it just turns out that Tuesday was the worst day I've ever had. So all of a sudden, everything I thought I was documenting, thought I was dealing with, turned out not to be true. And I said, there has to be a way where you and I can use some clinical experience to try to understand these pictures and what they look like. And this actually comes down to some of the stuff that you can even read from Malcolm Gladwell's book, The Intuitive Blink, right? Which is really based on Kahneman and Tversky's Nobel work on System 1 versus the System 2. Now, what this is, stay with me, listen to this very carefully, really important. When you and I go through training, we start learning about how to evaluate patients. What does it mean? What does it signify? And we start to see patterns. And we go through that laborious process. That's System 2. That's where we're doing learning, integrating, putting things together. But as we see more and more patients, as we keep practicing longer and longer, we start transitioning to a System 1 where things become more automatic. And there's ways of looking at patterns so that we can see the patterns that tip us off that there might be something operating here, right? So what we do is walk you through some questions and questionnaires that you can think about putting into your practice to try to help you and guide you into what things you may or may not want to do, right? So let's take a look. First of all, everybody does this, right? You ask people, what's your job title? How many years were you doing duties? Give them a questionnaire. Sometimes you'll get this. Look at this. Look, 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 look. So here's the job title, years of position, and the duties, right? Now look, I happen to pick this person because look, medical front office, medical record in the office, right? So you know these positions. Yet look at all the heavy written descriptions, right? That's starting to tell you that there's something going on. If you just say, what's your job and how many years were you there, you're not going to get this. Give them a questionnaire. Let them describe what's operating and let them put it on paper, and you start to see this pattern. Look at this. CNA, right? So those are the certified nurse assistants, right? Now, you've been in nursing homes before. You see what some of these folks do. It's there for a year and 2 months. But look at the job descriptions. And what's the most worrisome thing here? Sure enough, it's the arrow, right? You go, and here's page 2. This person is describing themselves in overly specific ways, very verbose, heavy on trying to bring you into their identity of their illness, how much they've been oppressed or hurt. It starts to let you see a pattern, right? Give them a questionnaire. Let them write it down. Let's see what happens. When you see a TMI, you know that you're into trouble, right? Look. I want to show you this one. Look at this. Look. Okay? Here's patient SS, okay? This person took 5 hours to fill out my questionnaire. That alone tells you right there you're in trouble. Give them a questionnaire. Let them sit in your waiting room for 5 hours. In the meantime, you can take care of other patients, right? And here's page 1. This is a person who worked in a kitchen, right? So you can see already, listed duties on the side, right? Here you go. This is page 2. All the server duties. I take food, I tabulate food, I keep all the work orders, I silverware, china, stuff, right? Look at this. Page number 3, right? Kitchen manager, supervisor, manual kitchen inventory, deal with that, right? What do you see there? What you see is somebody that's really talking about so many different criteria of things that bother them, things that they feel about, right? Give them a questionnaire. Don't just ask them what their job is. Tell them, here, put it down on paper. And if you start seeing people giving you this kind of response, you start to see a pattern, right? This is someone that's starting to show you some somatization, symptomification, right? These are the people that are going to go on to delayed recovery, chronicity of illness, right? We have to keep that in mind, right? Look here. This is patient 615. She had a PhD and she only worked for 3 months and she had 4 back surgeries, which no surprise did not work, right? She worked as a med tech, right? So look at all the circles, the boxes. It's, I'm dying, help me, reach me, right? And once again, we've got an arrow, right? This is not enough space. We got to go to the next page, right? And put down all the different criteria of things that bother us, right? This is not normal. This is someone that is having an overreaction. This is somebody that has taken on an illness identity. This is not the kind of person that you want to do surgery on. This is not the kind of person that you just want to say, go to regular physical therapy. This is not the kind of person you say, there's nothing wrong with you, go back to work, right? This is the kind of person that the red flags have to go up, and you have to know there's something going on. How do you get this? Give them a questionnaire, ask them, right? Next, on the questionnaire, we all do this, right? Job descriptions. We want to know, why did they have a certain injury? How often did they do things? Could they go back to the job, right? And give me a description of their job duties, right? So when you do that, here's what you get. Now, this is a patient who's a construction job site supervisor, right? Now, I want you to know something. This person, his job was he would take plans, put them in his pickup truck, and he would drive to different job sites. He'd unroll the plans on the trunk of the hood of the car, go over them with people, walk the site a little bit, roll it up, put it in, go to the next site, right? How is it possible that this person constantly, Ben Scott confidence that, look, Neil gets a star, repetitive feet. I want to make sure you know it's both feet, not just one, right? Checking up both boxes, right? This is physiologically impossible. You're entertaining somebody that's doing a dance for the Cirque du Soleil and bending and twisting everything different directions all at once. It's not going to happen. right? So this is the kind of warning that you're getting, that there's a pattern here, that this person is describing things in excessive terms, right? Next, give them a questionnaire. Ask them about lifting, right? You and I got to do this anyways, right? We got to know, could they have reasonably injured themselves? Could they go back to that work, right? What does that show? Well, here's our CNA, the woman working at a nursing home. I mean, all of a sudden, you're telling me that this CNA working at a nursing home, what is she doing at the nursing home? That she's constantly degrading 100. Are you kidding? I mean, is she bench pressing the residents, right? There's just no chance. This is not happening, right? So it tells you that there's a pattern, right? Look at this, right? This is the construction site supervisor, right? We talked about that. I told you. I asked him specifically, what do you do? And he told me about driving, unloading things. But when it comes to documentation, right? If you have it on paper, you can start to justify your opinions, support your analysis, explain your reasons. You can say, here's what he wrote down, but I know that that's not true. Therefore, some of his history is unreliable. His physical examination can be unreliable. Therefore, my analysis is based on the normal physiologic mechanisms, right? I once had, on this questionnaire, by the way, I put this as a reminder, motorcycle officer, okay? Now, police motorcycle officers do great service, but usually I find motorcycle officers in two locations. They're either on the highway looking at you or they're in a donut shop, right? So this gentleman was riding a motorcycle. I got to this, and he said he constantly did all this lifting. Now I said, look, Mr. Officer, sir, I understand that you put this down, but please forgive me. I think there's a lot of time where you're sitting, looking, doesn't seem like you can be constantly lifting. He said, well, Mark, the motorcycle weighs 900 pounds, and when you're turning the motorcycle, it's like you're lifting it. Okay, so, I'm not sure that's what is intended by the language, but what I do hear, what I do see, what pattern is emerging is this gentleman's not interested in going back to work. He's not interested in getting better. It's the kind of person that has taken on an illness identity, is trying to justify something for a claim, right? You need to know that. Get the documentation. Give them a questionnaire. Ask them the questions. Let's see what they respond. Okay, next, work history. Okay, now, you and I do this anyways, right? We always like to get a work history, right? And say, okay, were you hired anywhere near? If it's somewhere near this period of time, then you say, okay, did they hire you with any limitation? Or did they hire you to come work full? If you did that, you need to know that, because you can say, well, look, you may have gotten injured, you may have a problem, but it's clearly not that bad, right? And concurrent work, you have to drill down on this. Many times I say to people, are you working anywhere else? No. But you have to ask, look, are you working with a cousin, a brother-in-law, weekends, something like that? And sometimes you'll get the history that they're helping out, mowing lawns, painting buildings, whatever it is. You got to ask the questions, right? And prior work history. This becomes a very important area, right? Because prior work history can be very helpful. So let's take a look at some of this, right? Okay, so here's somebody that starts putting in their work history. Notice the descriptions of all the different tasks. Notice how critically important it is for them to really emphasize their words, to circle things, right? That's telling you that there's somebody that's showing you a pattern where they're feeling that they're being put upon, that they've been injured, they have significant difficulties, right? Take a look at this. This is very important. Now look. So this is a patient GG that work stressed her out. Now look at her work history. 90801, 898-1200, 299900, 1297-299, 797-8977. You see that? What you see is a history of frequent job changes, short job durations. This pattern is a predictor in the medical literature of patients who have difficulty operating in the work environments. The reason for their problem has nothing to do with their spine. It's in their mind, right? These are the people that have difficulties, and when they have difficulty, the problem becomes you. the employer, the doctor, the physical therapist. It's not them.